Hello students, so we'll talk about mechanical ventilation, positive pressure ventilation. So I'll talk about in this topic positive pressure ventilation. I will talk about very basic modes and just the basic of ventilation which is required at our level. Yes, so let me talk initially about the history, little bit, just few minutes about the history of mechanical ventilation. You know, Berzelius in 1555 gave the concept of mechanical ventilation, positive pressure ventilation, but it took nearly 400 years to develop that concept and use it during polio epidemic in 1955. During polio epidemic, there was a company called Emerson Company, electronic company. They produced a device which was used for giving positive pressure lung ventilation, right, in 1954, and from that the positive pressure ventilation started. From that era, the positive pressure ventilation started. So what is the history? Just few lines. Berzelius, I mean, imagine he gave it in 1555. Berzelius gave the concept of mechanical ventilation in 1555, right? But it took nearly 400 years to develop it, to understand this concept. So in 1955, during polio epidemic, first time positive pressure ventilation was done. Initially by manually, later a company called Emerson Company company developed a device for lung inflation, right? They developed a device for lung inflation. So guys, what is fundamental of positive pressure ventilation? What is the fundamental which we need to know? And fundamental, very simple. So we have to keep the thing simple. Fundamental principle of positive pressure ventilation. Positive pressure ventilation. Guys, I will write for positive pressure ventilation now PPV. Okay. The fundamental is that to create a pressure which will push a certain volume of gas into the lungs. So to create a pressure which will push a certain volume of gas into the lungs. This fundamental operates on two principles, two control. So we have volume control ventilation, in which I will talk about different graphs of volume control ventilation, and I will talk about that how volume control ventilation delivers and what are the settings we have to make on volume control ventilation. The basic of volume control ventilation is the pre-selected, whatever volume we have selected, pre-selected volume needs to be delivered. Pre-selected volume needs to be delivered. So I will discuss about its various graphs and how does it work. Then pressure control ventilation. Pressure control ventilation. In this, guys, pressure is pre-selected and inflation time is adjusted to deliver a particular volume. So in this pressure control ventilation, pressure is pre-selected. And inflation time is adjusted to deliver tidal volume. Okay. So in this I will tell you, we select inflation pressure and we select a respiratory rate, and accordingly inflation time is selected and a required tidal volume is delivered. Okay. So let us talk about volume control in little detail. There are two fundamental principles, volume control and pressure control, and let us talk about various graphics and various things about volume control ventilation. Volume control. Okay. As I already told you, tidal volume is selected. Okay. So when we put a patient on volume control, we select a tidal volume and this much tidal volume has to go to the patient. So at a constant inspiratory flow from the beginning of inspiration increases to the maximum level and remains constant till the required tidal volume is delivered to the patient. So tidal volume is selected and lungs are inflated. Lungs are inflated at a constant flow rate. Lungs are inflated at a constant flow rate till the delivered tidal volume is given to the patient. So definitely, depending upon the compliance of the lung, pressure in the lung would vary. Okay. So whether patient has a very good lung, uniform tidal volume would be delivered to him, or if the compliance of the lung is poor, so a very high pressure may be generated. But whatever, tidal volume which has been selected by us has to be delivered to the patient. And for this, flow rate, the inspiratory flow is kept high from very beginning. So what kind of graph we get for the flow rate against time? So graph of flow against time would be like this, right? Would be like this. This is flow time graph for volume control. This is flow time graph for volume control. Okay. Okay. So when this constant flow is being delivered, guys, how does the pressure in the airway varies? Pressure time graph. What would be the pressure time graph in volume control? The pressure time graph would be something like this. Like this. See, this would be peak airway pressure. Peak airway pressure. And this is the plateau pressure. Plateau pressure. Okay. This peak airway pressure is higher than plateau pressure because of this constant flow even at the end of inspiration. So this flow goes on even at the end of inspiration. So at the end of upper airways, the pressure would be higher than the pressure at the end of alveoli. Inspiration stops, alveoli got adequate tidal volume. The pressure should get stabilized there, but in flow of gases are still being delivered. Flow is constant. So even at end of the inspiration, there is a flow of inspiratory flow. So peak airway pressure would be more than the plateau pressure. Peak airway pressure, why it is more? Peak airway pressure is more than plateau pressure. Plateau pressure because of flow of gas. Flow of gas present even at the end of inspiration. Okay. So there would be a peak airway pressure. You know, plateau pressure is pressure at the alveoli, the highest pressure at the alveoli, and this is what is we need to control to prevent any barotrauma. So plateau pressure would be less, and even in volume pressure, let's say even the peak pressure is high, plateau pressure is low, and if peak pressure is going very high than the plateau pressure, then definitely there is a problem in the upper airway. There is resistance is high in the upper airway, and number of time when peak pressure and plateau pressure is varying to great extent, we do nebulization and dilate the upper airway, peak pressure decreases. So in volume control, we have one benefit, that we get an idea about the peak airway pressures and we get an idea about the upper airway also, right? And barotrauma and lung damage is caused by plateau pressure, not by peak airway pressure. And whether I put a patient on volume control or on pressure control, plateau pressure for a same lung would be same, right? So it is not that in volume control there is a higher incidence of barotrauma. There is another problem in volume control. In volume control, what is the graph of tidal volume in volume control? So what kind of graph we get of tidal volume? Something like this. We get a constant tidal volume, right? So what happens, that whatever tidal volume I have fixed, it reaches peak and then decelerate. Okay, so guys, important is that this peak, when it reaches that, let's say I have fixed 500 ml and it reaches that peak and the inspiration ends. So the inspiratory time is very, very less, and this prevents a evenly spread of the tidal volume in the lung. So there is uneven filling of the lung. So because in volume control, inspiratory time is less, right? Inspiratory time is less, short. There is uneven alveoli filling, uneven filling of the alveoli. Okay, so this is the major problem. What is the advantage? So this is the disadvantage of volume control. So there would be a possibility of uneven filling of the alveoli. What is the advantage? Well, advantage is obvious. A constant tidal volume would be supplied. Constant tidal volume would be supplied. Okay, so a constant tidal volume is supplied. Okay, so this is volume control. I talked about 3 graphs. I hope you have understood the graph. This is constant flow graph used in volume control. This is pressure time graph of volume control, where peak pressure would be higher than the plateau pressure, and this is the tidal volume graph of volume control. Okay, so let us talk about now pressure control ventilation. Pressure control ventilation. Pressure control. Okay. In this, as I already told you, inflation pressure is fixed, and depending upon the inspiratory rate, inflation time is adjusted to give a tidal volume. Okay, so inflation pressure is pre-selected. Inflation pressure is pre-selected. Duration of inflation is set to deliver tidal volume. I am writing TV for tidal volume. Okay, the duration of inflation is set depending upon the respiratory rate and inspiratory expiratory ratio. The duration of inspiration is set to deliver a tidal volume, but the pressure would not go beyond certain limit because the inflation pressure is pre-selected. Okay, so what kind of graph we will get? In unlike volume control, where there is a constant flow graph, here there is a decelerating graph. To give a tidal volume in pressure control, the flow is maximum in the beginning of inspiration only. So there is a decelerating flow pattern. So what we get, the rate of inflation, the rate by which the inflation of lung is being done, rate of inflation is decelerating type. Decelerating type. How? What kind of graph I will get? I will get something like this. Flow time graph for pressure control. I will get graph like this. Initially highest flow and then slowly it decelerates. Okay. Initially I am talking about inspiration. Highest flow, then slowly it decelerates. So this is the decelerating pattern. So I have a high flow in the beginning. So this is giving us a very important thing. It is giving us a even filling of the alveoli. So this will help us in even filling or uniform filling of alveoli. Okay, this will give us even or uniform filling of alveoli. Got my point? Okay. So this is pressure control. What would be the pressure time graph in pressure control? So as I told you, the pressure is pre-selected and it will not go beyond that pressure. So I would get graph like this. Okay. This is pressure time graph in the pressure control ventilation. And what would be the tidal volume graph in pressure control? So tidal volume graph would be like this. It would also be constant tidal volume graph depending upon the actually type of lung. Guys, if you notice, in volume control, a peak tidal volume was being reached, a maximum tidal volume was being reached. Here, since pressure is pre-selected, we have a more, during inspiratory time, there would be a more even filling of the alveoli because of a constant tidal volume throughout the inspiratory time being delivered. So this is a tidal volume graph for pressure control. What is the advantage? What is the advantage? Advantage is that pressure cannot rise beyond certain limit. Pressure cannot rise beyond the pre-selected limit. Okay, this is the advantage. And more comfortable, this mode is more comfortable. Okay. Third, more even alveolar filling. Okay. So these are the advantages of pressure control. Guys, remember that basically this is the fundamental of the positive pressure ventilation. Either modes are volume control or they are pressure control. In volume control, tidal volume is pre-selected. So depending upon the compliance of the lung, the pressure may vary from breath to breath, from lung to lung, etc. In pressure control, pressure is pre-selected. So depending upon the compliance of the lung, volume can vary, right? So volume can vary from breath to breath, from patient to patient. Got my point? So variable in pressure control would be volume, and in volume control would be pressure. So let us now talk about different modes. You know guys, today most of the mode can use both volume control and pressure control. Okay, so the breath delivered, they can be under volume control or under pressure control in any mode. So let us understand few basic modes of ventilation. So let us understand few basic modes of ventilation. I talked about fundamental principles. Now I am talking about modes of ventilation. Okay, guys, uh, in this I will talk about different modes, and I will talk about how to set those modes, what are the things, variables that we have to set while putting a patient on that mode of ventilation. So we need to be clear with few of the things written on the ventilator which we will see. So let us say TV, I will write TV. TV is written on the ventilator for tidal volume. Number of, you have to select it. Then F is for respiratory rate. Respiratory rate. Okay. FiO2. FiO2 is fractional inspiratory oxygen concentration. That is how much oxygen you are giving to your patient. Okay. Then there would be PEEP. PEEP is positive end expiratory pressure. So I'll tell little detail about PEEP also in few minutes. So in this video itself, positive end expiratory pressure. Positive end expiratory pressure. And there would be something called PS, which stands for pressure support. Pressure support. Now what is this PS? Well, if you have put a patient on a mode of ventilation on which his spontaneous breath is allowed, this pressure support would be the support during that spontaneous breathing, right? That extra push of air when the patient is breathing spontaneously would decrease the work of breathing of the patient. So that is what is support, pressure support. So pressure support in a arbitrary term, I am writing extra push of air to help during spontaneous ventilation. Spontaneous ventilation. Okay, extra push of air during spontaneous ventilation. Okay, so let us start with the first mode, that is the commonest mode practiced nowadays, assist control. Assist control ventilation. Assist control ventilation, ACV. Okay. What is assist control ventilation? Assist control ventilation allows the patient to trigger the breath. Okay, it allows the patient to trigger his breath. Or if patient doesn't trigger the breath, there is a time triggered breath. Okay, so in assist control, whenever we set the rate at that set time points, ventilator will deliver a pre-selected tidal volume or will deliver tidal volume within pre-selected pressure. Assist control can be volume assist control or it can be pressure assist control, both. It can be, remember, assist control can be volume control or it can be pressure control, both. Okay. This would affect how the tidal volume is delivered, by pre-selected pressure or by pre-selected fixed tidal volume. Okay. So what I am trying to tell you, in assist control, whatever rate I fix, on that rate, there would be time triggered breath by the ventilator. If patient triggers the breath at that time controlled, that would be patient triggered. That would be patient triggered, right? Ventilator will just help to achieve the pre-selected tidal volume or tidal volume within pre-selected pressure. And in between that pre-selected time, if the breath is again initiated by the patient, again that patient triggered breath will also be supported by the ventilator. So every breath, whether it is time triggered or patient triggered, every breath would be supported by the ventilator to deliver the tidal volume which has been fixed, or to deliver the tidal volume within the pressure which has been fixed. So let's say what I am trying to tell you, in assist control, this mode, few points I will write, this mode allows the patient to breathe. Patient can initiate a ventilator breath. Patient can initiate a ventilator breath, and this is called assisted or patient triggered breath. This is called assisted or patient triggered breath. Okay, but if it does not happen, patient does not trigger, it does not happen, then ventilator breath will be delivered, right, will be delivered. This is controlled. This was assisted and this is controlled or time triggered, controlled or time triggered. Okay, so this mode is called assist control. So the breath can be assisted or patient triggered, it can be controlled or time triggered by the ventilator. So if I draw an image for the breath, initiated breath in assist control, what would be the figure for the assisted breath in assist control? It would be something like this. See this. When a negative deflection is happening, during initiation of breath, right? This is patient triggered. This is being triggered by patient. Negative pressure generated, patient is triggering the breath, that is a trigger pressure, and then the breath is initiated, tidal volume is generated. In this, patient has not triggered the second one. This is time triggered. Okay, so this would be the two breaths during assist control mode. Okay, now let us say, how do I fix the parameters which I need to select in assist control mode? So in this, I have to select the tidal volume in case of volume control, or pressure in case of pressure control. So let me select volume control. So I am selecting the tidal volume. I would go for 8 ml during initial setting on assist control. I will go for 8 ml per kg predicted body weight. I mean, if it's obese, I would not overventilate. Predicted body weight. Okay, so I will fix a tidal volume. Then I will fix a respiratory rate. Okay, 12 to 14 breath per minute. Okay, 12 to 14 breath per minute, let's say I have fixed. Then what I will fix? I will fix a FiO2. Initial FiO2 during initial ventilator setting is normally 1, that is 100% oxygen is being given, and gradually it is reduced. So initial setting, it's always FiO2 1 is set on when ventilation is initiated, and then immediately after few, let's say 10-15 minutes, it is reduced to the required FiO2 level. Okay, then inspiratory flow rate. If it is a normal quiet breathing, the flow rate 60 liter per minute is enough. And if it is, let's say, labored breathing, then we have to set it above 80 liter per minute. Okay. Then inspiratory is to expiratory time, IE ratio. In per breath, how much time the patient will attend in inspiration and how much time the patient will be in expiration. Normally it is kept more than equal to 1:2. More time we need to keep the patient in expiration so that CO2 is cleared. And an asthmatic patient, etc., this 1:2 becomes 1:4 or 1:3, more time for expiration, okay, for CO2 clearance. Then PEEP. Guys, because of tube, endotracheal tube, the work of breathing of the patient has increased, and a physiological PEEP is always set when a patient is on, should be set when the patient is on ventilator. So always during initial setting, a 5 centimeter water of PEEP is set. So 5 centimeter of water. Okay. So these are the parameters I set, and one more very important parameter which I have to set is trigger pressure. Trigger pressure. That how much the negative deflection during patient triggering the breath would let the ventilator sense that patient triggered breath. So there is a trigger pressure which would be like -2 to -3, -2 to -3 mm of Hg. Okay. Now guys, these are the parameters we set in assist control. Now important thing I want to tell you, that what is the problem of assist control? Otherwise it's a very good mode, but the problem is that if patient is tachypneic, the disadvantage of this mode. If patient is tachypneic due to any reason, maybe central cause, maybe let's say pain, because of pain he is tachypneic, any reason, if the patient is tachypneic and he is triggering lot of breath, then every breath would be supported by ventilator. In assist control I told you, whether it is patient triggered or it is time triggered, every breath is supported by the ventilator and a full tidal volume is delivered. Full tidal volume is delivered. Okay, a full tidal volume is delivered. So what happens when patient is tachypneic? The minute ventilation of patient increases. Minute ventilation is increased in high respiratory rate, and this leads to respiratory alkalosis. Respiratory alkalosis. So if I draw a graph of tidal volume in assist control, it would be something like this. You are getting my point. Time triggered breaths are also being supported and patient triggered breaths are also being supported by the ventilator. So I am getting a uniform kind of tidal volume, and this will make a minute ventilation very high and respiratory alkalosis. So to overcome this, the next mode is SIMV mode. Synchronized intermittent mandatory ventilation. Synchronized intermittent mandatory ventilation. Okay, this is synchronized intermittent mandatory ventilation. Again I am telling you that SIMV mode can also be volume controlled SIMV or pressure controlled SIMV. So this can also be both volume control, that is volume control, and pressure control is the fundamental by which the tidal volume given to the patient is pre-selected volume or tidal volume within pre-selected pressure. Otherwise, other setting depends upon the mode. So volume control or pressure control. What is the difference of SIMV from assist control? Difference from assist control ventilation. Guys, the difference is that only those breaths which are at the stipulated set time, whether they are patient triggered or time triggered, they will be supported by the ventilator. In between breaths, between two time, fixed time, in between spontaneous breath of the patient, would not be supported by the ventilator. Depending how much tidal volume the patient generates, that much tidal volume will be generated. Okay, so all the breaths, in between breaths, are not supported by the ventilator. So in this, only breaths at fixed time is being supported by ventilator. Okay. In between breaths, not supported. Not supported. So whatever tidal volume I am able to take, I take in that. Okay. So let's say if I draw a tidal volume graph of SIMV, what kind of graph we will get? We get like this. This was fully supported breath. Then the next spontaneous was not supported, not supported, not supported. Then again this was not initiated by patient, but there was a time for the breath, so machine gave this breath. Again next was not supported, not supported, not supported. Then again time triggered breath, the patient initiated the breath, again it was supported. So in between the fixed timing, in between the fixed timing, these breaths were not supported by the ventilator. If you want to little bit help in this breaths, in between breaths, then in SIMV there was one more parameter which we need to set is pressure support, which I talked about. Pressure support is extra push of air during spontaneous breathing. Okay, so what are the things we set in SIMV? Let us talk about SIMV volume control. SIMV volume control. Okay, so I am writing SIMV volume control. Okay, we can have SIMV pressure control also. In this again, pre-selected tidal volume. Let's say I selected 8 ml per kg predicted body weight, then frequency, respiratory rate I selected 14 breath per minute. Always a physiological PEEP I will select. I can increase if it is required, but basic physiological PEEP 5 centimeter of water. Then inspiratory flow, as we have written in the last also, that if it is a normal quiet breathing, let us say 60 liter per minute. FiO2, in initial setting parameter always FiO2 1, that is 100% oxygen is started and then gradually it is reduced. Then pressure support. Guys, I told you that in SIMV mode spontaneous breaths are not supported by the ventilator. So to help during those spontaneous breath, a pressure support we can apply, which is just an extra push of air. See, if the breath will be fully supported by the ventilator, it has to deliver the fixed tidal volume which I have fixed, right? If the breath is not fully supported by ventilator, so whatever tidal volume I can initiate, I will initiate that much. Little support I can get by pressure support, that is extra push of air. So normally we keep a pressure support of 8 to 10 mm of Hg. Okay, so this is how we initiate the SIMV mode. So remember again I am telling, I talked about two basic mode, assist control and SIMV. Assist control can be volume control or pressure control. Assist control mode can be volume control or pressure control. SIMV mode can be volume control, pressure control. The only difference is that this is SIMV volume control. If I make it, see, if I am fixing on SIMV volume control, I fix a tidal volume here, right? But if I am setting on SIMV pressure control, then I select a pressure control. Let's say I selected 35 mm of Hg. Okay, right? Here I selected, let's say 500 ml of volume. Again in both I will select the respiratory rate. Here I selected 12 breath, here also I selected 12 breath. Then again I will selected the PEEP, let's say 5, here also PEEP is 5. FiO2, rest of the things would be more or less same. FiO2 1, let's say FiO2 1, and it is SIMV, so I will also add a pressure support. Here 8, here pressure support also 8. So in volume control, this much tidal volume has to get delivered. This much tidal volume has to get delivered. Okay. And in pressure control, within this much pre-selected pressure, depending upon the inflation time, one important thing is that IE ratio also. IE ratio also we select 1:2, here also 1:2. Depending upon the inflation time, which depends upon the respiratory rate. So I have 12 breaths per minute. This is divided into 12 is divided by 60. So what will happen that this much time, this much seconds per breath would be spent. Of this 1:2, that is 1/2 times is in inspiration and 2 times the inspiration time it is in expiration. So depending upon this inspiration time, that amount of volume will go from in pressure control. So in pressure control, within a pre-selected pressure, a desired volume would be delivered. Okay. When we have put the patient on these modes, there are certain parameters we need to see. In volume control, we see something called plateau pressure. Plateau pressure, right? Now, in pressure control also we see plateau pressure. Okay. In volume control, we also see peak pressure. Now, peak pressure would always be high in volume control. In pressure control, there would be no peak pressure because of the decelerating flow pattern and fixed upper limit of the pressure. So, let us say here the plateau pressure is 30, here also 30, and peak pressure here is 35 mm of Hg. So, here up one more parameter reading I will get, that is the peak pressure. In both I will get a reading of minute ventilation, but how much tidal volume the patient took. In volume control, the volume would be fixed. Okay. Here the volume would vary, right? Volume would vary. Volume is fixed. To deliver that volume, this pressure would vary. You are getting my point? This pressure would vary. So just we have to keep this in mind. Okay. So this is about the two very important mode. Now I will talk about few spontaneous mode in which I will tell you about pressure support, CPAP and BiPAP. Okay. But before I tell you those things, I want to talk about an important setting which I did in the ventilator, that is PEEP. What is this PEEP? Which stands for positive and expiratory pressure. Positive and expiratory pressure. Okay. Guys, there is a progressive narrowing of alveoli during expiration, okay, which can lead to the collapse of alveoli. So, first thing I just wanted to tell you that progressive narrowing of airways during expiration, alveoli is getting empty, culminate in collapse of distal air spaces, that is alveoli and small airways of distal air spaces. Okay. So, what is done? A positive pressure is applied during expiration, throughout during expiration to prevent this collapse, right. So, when the alveoli is getting emptied, its pressure is being reduced and it will get emptied till the time the positive pressure is set by us. It will not be emptied below that levels to reduce the pressure, which can lead to the collapse of the alveoli. See, if transpulmonary pressure would become equal to the closing pressure of the alveoli will collapse. So what we do, by applying a positive pressure, we try to keep it more and prevent the collapse of alveoli. So what do we do? The risk of alveolar collapse can be eliminated by preventing the pressure to fall, below the closing pressure, at expiration. Okay. So let me explain you that this is lung and there are alveoli, distal air spaces. So a positive pressure is applied in them to prevent it to get collapsed, to prevent it to fall below the closing pressure, to prevent it getting collapsed. So when this positive pressure is applied and this prevents the collapse of the alveoli, what would happen? The alveoli will remain expanded and the surface area of the alveoli would be more, and throughout, even during expiration, there would be a nice O2-CO2 exchange. So the O2-CO2 exchange time would increase and oxygenation of the patient would improve. PEEP has two major benefit. Improves oxygenation by alveolar recruitment, right? It improves oxygenation by alveolar recruitment and prevents the collapse of alveoli. So it improves the pressure and prevents the collapse of, improves the oxygenation and prevents the collapse of alveoli. So it will prevent collapse of alveoli. Now guys, always when a patient is put on ventilator, a physiological PEEP is applied. I told you, a physiological PEEP is applied because work of breathing has increased. This will lead to the collapse of the distal airways. So 5 cm of water PEEP is minimum what we apply to the patients on mechanical ventilation, and if it is required, it can be increased. PEEP can be increased. To improve oxygenation. Okay, so PEEP can be increased to improve the oxygenation. Got my point? But when we are increasing the PEEP, there are some disadvantages of increasing the PEEP. There are some side effects of increasing the PEEP. So there are some disadvantages of increasing the PEEP. So what are the disadvantages of increasing the PEEP? So whenever you apply PEEP, intrathoracic pressure, overall intrathoracic pressure increases, venous return decreases, and cardiac output decreases, and blood pressure etc. decreases. So disadvantages, number 1, it decreases venous return by increasing intrathoracic pressure. So preload is getting decreased, okay, by increasing intrathoracic pressure. So this will lead to decreases cardiac output. This will lead to decrease in cardiac output, okay. And because of this increased intrathoracic pressure, the pressure which is applied in the distal alveoli prevent it from collapsing. Sometimes air trapping etc. can happen, and this can lead to barotrauma. So increased intra-alveolar pressure can cause barotrauma, okay. Then what is the other problem? If cardiac output would reduce, then if the cardiac output is decreasing, then what will happen? That perfusion of the organ would be affected. Perfusion of organs would decrease. So urine output can decrease at a very high PEEP, etc. Okay. Because of the pressure of the PEEP, it also increases afterload and decreases ventricular compliance. So it increases even afterload. Increases afterload, increases ventricular compliance. Okay, so these are all the demerits of PEEP. Basic demerits is that intrathoracic pressure is increasing, so barotrauma can happen. Intrathoracic pressure is increasing, so venous return is decreased. Venous return is decreased, so cardiac output is decreased. Cardiac output is decreased, the perfusion is decreased. Afterload is increased, so again cardiac output is affected. So all this can cause hemodynamic imbalance. So we always have to titre and at what best PEEP and at what best FiO2 adequate oxygenation can be done. So for improving oxygenation, right, you can only do two things, and two basic things. I am just talking basic. You can increase FiO2, that is fractional inspiratory oxygen concentration. As and as more oxygen you will give, more and more oxygenation. And second, you can increase PEEP. So more time for exchange would be there. So both have their own demerit. Increasing FiO2 has risk of oxygen toxicity, and increasing PEEP has risk of barotrauma, has risk of hemodynamic imbalance. So we titre at what best PEEP and best FiO2, just adequate oxygenation is achieved. Okay. If you have to improve the ventilation, that is, you have to decrease CO2, hypercarbia is happening. In improving oxygen, you are increasing O2, that is, you are increasing PaO2. If your PaCO2 is increased, so decrease PaCO2, you have to improve ventilation, which could be done by increasing the minute ventilation of the patient, by increasing minute ventilation. Okay, so depending where is the problem, the setting, the parameters of the ventilator is changed. Okay, so again very fast before going into non-invasive ventilation, I just want to tell you that whenever you do a ventilator setting, you always set the tidal volume or pressure control. For volume control, you set the tidal volume, and for pressure control, you set the pressure control. Then you set the frequency. Then you set, let's say, FiO2, then PEEP, then inspiratory flow, and pressure support when you are using SIMV. If you are not using SIMV or using assist control, then you need not put a pressure support, right? Pressure support would not be required to set. Okay, so these are the settings which we do. Remember, tidal volume, always we start with 8 ml per kg of predicted body weight, then reduce it to 5 ml per kg body weight. Respiratory rate, depending upon PaCO2, I can set. Normally 12 to 14 breath per minute we set. Never more than, always less than 35 breath. Never more than. FiO2 initial setting, always 1. Gradually we reduce. Reduced gradually. Okay. PEEP, depending upon the patient. If patient oxygenation is fine, then also a basic PEEP of 5 cm of water. If required, I can increase the P. Okay. Inspiratory flow at a normal regular breathing 60 liter per minute, and at labored breathing more than 80 liter per minute. Pressure support I can set 8 to 10 mm of Hg. Okay. And trigger pressure depending upon how much breath the patient is generating and how much trigger and how many breath we want it to be supported. So normally we fix a trigger pressure also, right? So this is the setting for positive pressure ventilation. Okay. Now positive pressure ventilation, these parameters were for invasive ventilation when we put endotracheal tube and ventilate. There is another option when, depending upon the patient, we can also select a mode called non-invasive ventilation. Whenever we intubate a patient and put a patient on ventilator, there is always a risk of many complications, especially complication like ventilator associated pneumonia, VAP, right, which would increase mortality and morbidity in the patient. So we have another option that's called non-invasive ventilation. So what is this non-invasive ventilation? Non-invasive ventilation. So non-invasive ventilation is a mode of ventilation put in a patient with acute respiratory failure without a invasive airway device like endotracheal tube. In non-invasive ventilation, there is a tight sealing fitting mask which is strapped on the patient's face with mask strap, and patient is ventilated. There are certain indications in which non-invasive ventilation has very good role, and there are certain contraindications where you cannot initiate non-invasive ventilation. So, few things we have to know about non-invasive. So, let us talk about non-invasive. I will write now NIV. Non-invasive ventilation is intended for patients. Non-invasive ventilation is intended for patients in acute respiratory failure who will definitely have a benefit from ventilatory support, who will have benefits from ventilatory support, but they may not need conventional invasive ventilation. They may not need, the requirement is not that extent, they may not need conventional invasive ventilation, invasive mechanical ventilation. Okay. So, they may not need that invasive ventilation. How do we give non-invasive ventilation? It is given, NIV is delivered, it is delivered via tight fitting face masks, right. We have tight fitting face mask which forms a very good seal over the patient's airway. It is given via tight fitting face mask. The most popular mode in NIV. Three important modes. There are three modes of ventilation popularly used in NIV. Number one, CPAP, continuous positive air pressure, CPAP. Second is BiPAP, bi-level positive airway pressure. Okay. Then we have pressure support ventilation. Which pressure? This is the same pressure support which I am applying even in invasive ventilation, like modes like SIMV, when patients spontaneous breath I want to support. So in Pressure support ventilation, that's extra push of air which I am giving to the patient during spontaneous breathing, and this extra push here I am giving through NIV mask. Okay, so CPAP stands for continuous positive airway pressure. BiPAP, bi-level positive airway pressure, and pressure support ventilation is PSV, pressure support ventilation. Okay. Now, what is this CPAP? Guys, whatever is PEEP in a mechanically ventilated patient with invasive ventilated patient, CPAP is in a spontaneously ventilating patient, that is breathing at a positive airway pressure. Okay, CPAP is spontaneous breathing at positive and expiratory pressure. Okay, CPAP is spontaneous breathing at positive and expiratory pressure. It is very simple to design. You just have to have a mask, a tube and a valve in it. So when we close the valve, a positive pressure is generated in the circuit and patient breathe through that positive airway pressure. So airway is not collapsed, airway is not compromised in this case, and work of breathing of the patient is reduced. So it is simple to design, it is simple in design and requires only a source of oxygen and a face mask with an expiratory valve, face mask with expiratory valve to maintain that positive pressure, that maintains a positive pressure, right? Okay. Guys, basic funda of CPAP is to increase the FRC, functional residual volume of the patient, capacity of the patient. So, the principal effect of CPAP is to increase FRC, and normally we set it at 5 to 10 centimeter of water. Okay, we can increase it also, but normally we set it at 5 to 10 centimeter of water. Simple thing, guys. Even in operating room, patient has come on spontaneous breathing but is unable to take full tidal volume. So just to support him, patient is coming out, patient is trying to breathe but is unable to take full tidal volume. I just close the expiratory valve and generate a positive pressure. This patient breathes through this positive pressure and work of breathing is reduced. So because FRC of the patient is increased. Okay. Okay. So what is BiPAP? Bi-level positive airway pressure. It is same as CPAP, but it operates at two different pressure level. Is CPAP that alternates between two pressure level, right, which is called IPAP and EPAP. Guys, IPAP is inspiratory positive airway pressure, the higher pressure, that is higher pressure level, and EPAP is expiratory pressure, positive airway pressure, that is the lower pressure. So between two pressure, the patient alternate, and generally more time is spent on the lower pressure, right? More time is spent in lower pressure. Okay. Now, this again is same as your CPAP, only along with FRC, which was increased in CPAP, FRC is also increased in BiPAP. Along with that, there is bit alveolar recruitment also happening. So, this has an added advantage. This has an added advantage because of two level of the pressure, advantage of alveolar recruitment. Okay, this is our BiPAP. Now coming on PSV, I talked about little bit about PSV. PSV is called, if I pressure support ventilation, if I further expand it, it is pressure augmented spontaneous breathing. Pressure augmented. CPAP pressure augmentation was not being done. Only a positive pressure was created. Here a pressure augmentation is being done. So pressure augmented spontaneous breathing. Pressure augmented spontaneous breathing. Okay. Now guys, this differs from pressure control ventilation. In pressure control ventilation, we set a pressure control, right? It differs from that because in this mode, patient can initiate his own inspiration and expiration, his own inspiratory time, which could not be done in pressure control ventilation. There the respiratory rate is fixed and inflation time is fixed. And during that inflation time, the ventilator will deliver a tidal volume within the pressure, right? But here, the patient can stop his inspiration at his will. This is a spontaneous mode of breathing. So, it differs from patient triggered. Patient in PCV also patient can trigger his breath, but it differs from that breath also. Patient triggered PCV because it allows the patient to terminate his lung inflation. Okay. It allows the patient to terminate his lung inflation. Whereas in pressure control ventilation, ventilator can only terminate the patient's breathing. Ventilator terminates the lung inflation. Okay. So, in this patient can terminate, and in PCV ventilator was terminating the lung inflation. Okay. So, pressure control, in pressure control ventilation, patient cannot control his inspiratory time. In pressure support, patient can control. So, pressure support ventilation allows patient to control his inspiratory time and tidal volume. So, the only thing which changes in pressure support ventilation is the pressure and the flow. So, the changes in pressure and flow during lung inflation helps the patient in pressure support, helps the patient. The only thing which ventilator is doing, this pressure changing through the lung inflation and flow, pressure and flow is being helped to increase, helps the patient. Okay, this is what the ventilator is doing. It's a pure spontaneous mode, right? Pressure support ventilation also has a decelerating flow pattern. Here also a positive flow is given in a decelerating flow pattern as in pressure control, but here the inspiration, patient can stop his own inspiration, can fix his own inspiratory time, unlike pressure control ventilation where patient cannot fix his own inspiratory time. Whatever respiratory rate has been fixed, whatever IE ratio has been fixed, accordingly ventilator will operate in that mode. But here things are under patient's control. So this is pressure support ventilation, a pure spontaneous mode. So 3 spontaneous mode I told you, that is CPAP, BiPAP and pressure support ventilation. Okay. Now a very popular thing nowadays must be in because of the COVID-19 is something which is on everyone's mouth is prone ventilation. What is this prone ventilation? I would not go in detail. Prone ventilation. What is this prone ventilation? Now, it is not a ventilatory mode. Prone ventilation refers to patient being ventilated in prone position. So, prone ventilation refers to the delivery of mechanical ventilation in prone position. So, I am giving ventilation in prone position. Got it? It is not a mode. Just we are ventilating in prone position. Any mode can be set in this. Either volume control ventilation or pressure control ventilation. Any mode can be set on it. Now, what is the physiological good changes which the proning brings to someone is what is giving benefit in prone ventilation. So, what are the benefits? Benefits of prone ventilation, physiological effect of proning. Effects of proning on oxygenation. Very basic I have told you, I am not going in detail. By proning, there is more homogeneous ventilation. More homogeneous ventilation. Right? The ventilation is more better distributed, more even. Second, reduced lung compression. Heart is compressing the lung. By proning, the heart goes down. So, there is less reduced lung compression. Improves lung perfusion. So, guys, ventilation is improving, homogeneous it is happening, perfusion is getting better, pressure on the lung is minimized, so alveolar collapse is prevented. So, definitely VQ mismatch would be minimized and more oxygenation would be achieved. So, this proning helps in a better oxygenation and this would help in reducing the FiO2 of the patient, right. So, this improves better oxygenation, increases the PaO2 of the patient, allowing us to decrease FiO2, right. Number of times when the patient is on very high FiO2, very high oxygen concentration, we want to reduce it. We want to reduce it and this is helping us, proning is helping us in doing so. Okay, now guys, there is no such, in ARDS for example, it is told that in severe ARDS we should go for prone ventilation. There was a very popular trial called ProSEVA trial, the prone ventilation trial. It said that when PaO2 FiO2 ratio is less than 150, right, at FiO2 above 0.6 and PEEP above 5, then the prone ventilation should be, then prone ventilation should be initiated in a patient of ARDS. Then prone ventilation should be initiated, right. Now guys, there are few contraindication of prone ventilation. If a patient is in shock, we never go for prone ventilation. Acute bleeding, trauma, multiple fracture, then spinal instability, spine is unstable, pregnancy, pregnancy. Raised ICT, raised ICP above 30 mm of Hg, or less cerebral perfusion pressure, or tracheal surgery or sternotomy within 2 weeks. So, recent tracheal surgery or sternotomy, these are few contraindications of prone ventilation. It is not that feeding is not allowed during prone ventilation, but number of times it can cause complications. So, normally feeding is withheld during prone ventilation period, and it is not that how much time for the short period for prone ventilation or longer period of prone ventilation. I mean, nothing, there are a lot of studies done and nothing fixed is decided for this. There is two things, for the optimal duration of prone ventilation, or optimal duration of prone ventilation, still unknown, still unknown. Two things actually, there are short, repeated sessions of prone ventilation lasting 6 to 8 hours per day, right, or prolonged session of 17 to 20 hours per day. So, it is not actually which is better. Lot of studies, few have done short sessions, few have done long session, but most of the centers in India, guys, and most of the centers even outside, they say the prolonged sessions are better, because repeated turning the patient prone can cause problems in the patients, in ventilated intubated patient. So, this is in few studies showing to be the better mode, prolonged session for 17 to 20 hours per day. So, this is all about our prone ventilation. Now, I just want to tell you that when you put patient on ventilation, it is the requirement, patient must be in ventilation disorder or hypoxemia, then only patient has been put on ventilator. But there are a lot of complications of putting a patient on ventilation, a lot of let's say side effects which comes along with ventilation, and one very important is ventilator associated pneumonia. So, just few lines about that. What is this? Ventilator associated pneumonia. I just want to give you the definition of ventilator associated pneumonia, and I want to tell you there are something called VAP prevention bundle. There are few things which we do to the patient who are on prolonged ventilation to prevent developing VAP in those patients. So, I would just talk about these two things. So, what is ventilator associated pneumonia? Ventilator associated pneumonia, it is defined as hospital acquired pneumonia, hospital acquired pneumonia that occurs more than 48 hours after endotracheal intubation, right, which occurs 48 hours after endotracheal intubation. So, when the patient is put on ventilator and after 48 hours if any pneumonia is developing, it is called ventilator associated pneumonia. If it is within 72 hours, it is early, and after 72 hours it is called late. And early is with let us say the late ventilator associated pneumonia is more with multi drug resistant microorganism. So, they are bad, they are more bad. So, late and early, early means, early onset means less than 96 hours, that is within 72 to less than 96 hours, and late is more than 96 hours. Late means more risk of multi-drug resistant microorganism. More risk of multi-drug resistant microorganism. Now guys, what is the problem? Why is this happening? So whenever you put a patient on mechanical ventilation, this is the alveoli, glottic opening, this is the trachea. You have put the patient on tube and you are ventilating the patient. So whenever a tube is placed in the respiratory tract, the anatomy and the physiology of the respiratory tract is affected. What happens? Above the tube, the secretions, etc. are accumulated. Patient is intubated, patient is paralyzed, patient cannot cough, patient cannot remove those. Slowly through the tube, these secretions seeps inside the lower respiratory tract and they are known to cause ventilator associated pneumonia. So, ET tube disturbs normal anatomy and physiology of respiratory tract, right. So, because of this VAP is taking place. So, there are few measures which is important. VAP prevention bundle, ventilator associated pneumonia prevention bundle. So, reducing the, why this is happening? Because of the slow aspiration, slow moving of the secretions to the lower respiratory tract. So, reducing, first set of bundle would be to help in reducing aspiration. So, what are the things we can do to reduce aspiration? Guys, if the patient is nursed in a prone position, chances of secretion going to the lower respiratory tract is more. So, nursing in semi-prone position, nursing in semi-recumbent position, that is 30 to 45 degree Celsius. The cuff, which is the inflated to prevent aspiration, we have to daily check the pressure of the cuff and maintain its adequate pressure. Maintain tracheal cuff pressure above 20 mm of Hg. Then a special tube comes. Guys, the secretions are here. So, there is a subglottic drainage attached to the special tube, which will drain, we can take out the secretion, we can suck out the secretion from the subglottic drainage tube. So, tube with subglottic drainage. Endotracheal tube with subglottic drainage. Okay. Fourth is that undue change of the tube should be avoided. Whenever you are deflating and removing the tube, there is always a risk of passing the secretion to the lower respiratory tract. So, undue and unnecessary tube change to be avoided. Okay. So, these 4 measures would decrease the risk of aspiration. Now, we have to optimize the patient's microbial flora. So, optimizing patient's microbial ecology, the microbes in the patient. Every patient is given stress ulcer prophylaxis under mechanical ventilation. Nowadays is not recommended. When you are giving the H inhibitor, the cimetidine or ranitidine or omeprazole to all the patients, this affects the gut pH and leads to the growth of different kinds of bacteria. So, stress ulcer prophylaxis nowadays is not recommended for every patient. It is only recommended for high risk patient. So, avoid stress ulcer prophylaxis in every patient, only given in high risk patient. Basic oral hygiene should be maintained. Infection control, whenever you are touching the patient, proper hand washing, sanitizing, etc. should be done. So infection control measures should be taken. Now apart from this, decreasing, we have to try to decrease the days of patient on ventilator. So minimizing days on ventilator. What do we do? Daily sedation break. Daily sedation break. Patient should not be always kept heavily sedated and his respiratory effort should be completely abolished. Daily there should be sedation break so that patient's respiration should be encouraged to breathe. Then only patient will come out of the ventilator while his lung is improving. So daily sedation break, daily assessment for extubation. Even if the patient is not ready, then also daily assessment for extubation, right? And always, whenever a patient develops VAP, we should always have a backup of the local microbial ecology of that particular hospital, that what kind of microorganism is causing VAP, etc. Because initially when you start antibiotic, till the reports come, if you have a microbial ecology, you will know which antibiotic you have to start, because as early you start an antibiotic in ventilator associated pneumonia, that is the better chance for the patient. Okay, so these are just the VAP prevention bundle, ventilator associated pneumonia prevention bundle. Okay, so this is all I want to talk in positive pressure ventilation. Very briefly I have discussed it just to cover the questions which is being asked in PG entrance exam. Otherwise it's a very big topic, very complicated topic. Thank you.